Yeah.
Hi, Dr. Srinivas. How are you?
Yeah, good, great. Good.
Dr. Ramesh from Hyderabad.
Madurai should be a good place for you to see.
It's a wonderful place.
Yeah. Hi, Dr. Ramesh. Nice to start off with our patient. You just saw one intravascular ultrasound, and I thought we will show you intracardiac echo today. I have my colleague Dr. Avinash who is going to do the ASD closure, and Dr. Ramya Shri will be assisting with the intracardiac echo. And I request Dr. Sandeep, my colleague, to give the clinical scenario. Sandeep, PowerPoint.
Good morning everyone, greetings from MADRAS Medical Mission. Our patient, 26-year-old Mrs. A, mother of 2 children, presented with NOHO dyspnea on exertion for 6 months. She was diagnosed to have congenital heart disease 1 month back. She is not on any cardiac medications. On examination, weight is 43.9 kg, height is 149 cm, pulse rate is 84 per minute regular, respiratory is 24 per minute, saturating 100% in room air, blood pressure is 110/70 millimeters of mercury. On CVS examination, JVP is not elevated, there is no cardiomegaly, S1 is normal, S2 is wide and fixed split, 3/6 ejection systole in pulmonary in the pulmonary area, other systems are normal. The X-ray showed cytosolitis, levocardia, CTR ratio of 50%, RV apex, MPS segmented dilated, left arch with bilateral pulmonary plethora. The ECG showed sinus rhythm, ventricular rate of 75 per minute, QRS plus 75, PR interval of 120 milliseconds, QRS duration of 100 milliseconds with RSR pattern in V1. This is a transesophageal echocardiography, mid-esophageal view, 0 degree, showing the aortic margin of the ASD along with the posterior inferior margin of the ASD with the aorta. This is another transesophageal echocardiography, mid-esophageal view. This is a TE mid-esophageal bicable view showing the SVC and IVC with the superior and inferior margins. This is a 3D transesophageal echocardiography with a full width acquisition showing the atrial septal defect. The S denotes the superior margin of the ASD, S is the anterior margin of the ASD, I is the inferior margin of the ASD, P is the posterior margin of the ASD. SVC is shown at the top, aorta is marked as AO at the right upper part of the screen. Todaro points to the tendon of Todaro, and the tricuspid valve is also seen in this. This is another 3D transesophageal echocardiography, so with full width acquisition showing the atrial septal defect. With the maximal measurement of the ASD that is got was 22 millimeters in the bicable view. Plan is intracardiac echocardiography guided transcatheter device closure. Thank you.
Shiva, this is a
Dr. Srinivas?
Yeah, this is a great case. You have good margins all around, posteriorly, inferiorly, anterior.
Exactly.
Even aortic is also has got a good margin actually, and it's quite circular rather than oblong.
Exactly.
And
so the ASD is measuring around 21 to 22 millimeters.
yeah.
So what we got in the morning was the superior inferior vena cava saturations and pulmonary artery saturations. There was 19% step up, which gives 2.2:1 left-right shunt. The pulmonary artery pressures are normal. So right now I want to go live on the intracardiac echocardiography. Can you go live on echo? So now what we are seeing is called as, I will show the parallel fluoroscopy also. Show side by side fluoroscopy and echo. Because so anyhow, so this is the tricuspid valve. So now you can appreciate the small Eustachian ridge there on the top shown by the arrow, and then the tricuspid valve, color the tricuspid valve. So this is color flow across the tricuspid, which does not show any regurgitation, color off. So if I push the catheter a little bit up, you'll be able to see the right atrial appendage. So after seeing the right atrial appendage, now if I clockwise rotate, I will be seeing the right ventricular outflow tract and the pulmonary artery.
The fluoro is on, but not the eyes.
Okay, show the echocardiography big.
Make the fluoro small.
Make the fluoro small. Or if it is not possible, just show the echo alone. Yeah, okay. So this is the tricuspid valve, and you are able to see the aorta, that is the aortic valve, and beyond the aorta is the pulmonary valve. So now I am clockwise rotating. I am now getting the coronary sinus as a round end-on structure which was draining into the right atrium, and as I rotate further, this is the mitral valve. And as you are seeing the mitral valve, just above the mitral valve is the left atrial appendage. Color the left atrial appendage. Doppler the left atrial appendage pulse wave. So this is the pulse wave across the left atrial appendage of color, of Doppler. So right now if I clockwise torque further, I will be getting the pulmonary veins, color now. The red flow that is coming is the pulmonary veins. This is the left pulmonary veins. Doppler the pulmonary vein. So this is the pulmonary venous Doppler with the atrial systolic flow reversal seen immediately after the P wave of color. So now I get back to my neutral position, and now you can see that I am retroflexing the probe. As I retroflex the probe, I will be exposing the atrial septum and the ASD. So that is the atrial septum, and color the atrial septum. So this is the color flow across the atrial septum, and this unlike in the transesophageal echocardiography where you see the flow blue in color because the flow is going from posterior to anterior, here it is coming from left atrium to right atrium, and so you will be seeing the color red. So right now Dr. Avinash will be starting the ASD closure. So Avinash, we can enter the. Any questions, Dr. Ramesh, Dr. Srinivas?
Now, how often do you use ice in your practice, or is it you're doing it in every case, ice?
No, it is excessive catheter. Since Dr. Ajit was planning to show an intravascular ultrasound guided coronary intervention, we thought we will show an intracardiac echocardiography just to match
Okay. No, but
an
it's
image guided intervention.
Yeah, but the images are great actually. It's so easy to understand.
Yeah, basically since it's a very close field, the pictures will be extremely good. There are no artifacts that are possible. The window is very, very clear.
Resolution is very clear.
Yeah, this is the Siemens Acunav catheter, which is a 10 French catheter, which is 2-dimensional. There is a newer generation Siemens Acunav catheter which is called Acunav V, which is 3D catheter. So that one will be even more useful, especially if you are doing some major procedures like left atrial appendage device closure and all. So the sheath is being advanced across the atrial septum towards the left upper pulmonary vein.
What is the size of the device you have chosen?
The size of the echocardiography was 21.4, so we decided to choose a 24 millimeter device.
Okay.
We don't use balloon sizing. I want to show the device now. This is an Occlutech ASD device. The Occlutech ASD device is something similar to Amplatzer device, but there are some few small differences. the left atrial hub is absent, and so the left atrial hub, which is a small stainless steel hub, will be I mean theoretically a potential source for a left atrial
thrombus,
appendage, like left atrial side thrombus.
Yeah.
So here that is less likely. The second thing is, unlike an Amplatzer, LifeTech, Cocoon or any other device which are mounted with a screw, their device will be perpendicular to the cable. So very often what will happen is the device will be, if the atrial septum is not perpendicular to the inferior vena cava, the device will be held with some tension, and often when you release, the device will jump back to its natural lie of the atrial septum, and that particular situation might give us a little anxious moment. So the occlutech has got an angulation, so it will angulate according to the atrial septum. Whichever side the atrial septum is, it will get angulated. So that is the second difference. The type of deployment is also different. It is actually something like a bioptome-like device. So you can see that the bioptome is now opened, and we catch the hub of the device with the bioptome. And so the device actually sort of is flexible in the angle between the cable and the device. So right now we are de-airing the system. So putting underwater, and we are expelling the air from the device. I'll flush the left atrial sheath also now. Yeah.
Only issue will be after deploying, Dr. Shiva, this particular device.
Yeah.
How?
Yeah.
See, it is like a bioptome. The mechanism is like a bioptome, right? You are going to once. So once you release, there is. What about the retrieving situations? Is it possible?
It's a little bit more difficult. It's
to retrieve.
more difficult compared to.
Yeah.
Exactly.
Yeah.
Exactly. It's a much more difficult to retrieve.
So you have to be absolutely sure before you deploy that.
Exactly. Exactly. Yeah. Color now? Actually, yeah, okay, echo you are seeing small and fluoro big. Yeah, go ahead. So start with drawing. So doctor, color off. He's opening the device. Yeah, open the full device. So the entire device has been opened now, little bit more. Yeah, approximate the atrial septum. So we can appreciate the device coming closer to the atrial septum. Keep coming. Little bit more. Yeah. Start peeling off the. Little full. Little full. Yeah. Start deploying. Yeah. Push. Yeah. So you were, I think, watching the echocardiography in a smaller screen.
Yeah.
Can you see that clearly?
Yes, yes.
You can make it bigger.
It is very well deployed. Actually, the left atrial disc is on the left atrium, left atrial side, and the right atrial disc is on the right atrium, and we can see that the margins are being held by the disc very well, actually. And the way it has collapsed is very, it's a good feeling, actually.
Color. So right now we are coloring across the atrial septum. So what we are seeing on the rightward side of the screen is the aorta. So that is the retroaortic margin, and the other side is the posterior and inferior margin. Yeah. Now color off. So right now I will do some more manipulations and
Do you do the Minnesota regular also?
Can be done. If you want, I will do that also. Okay. Now color the. This is the inferior margin. You can see the inferior vena cava. The red color that is coming proximally is the inferior vena cava. What Dr. Ramya is showing, and just in front of that is the IVC margin, and the device is catching the IVC margin. So now I am rotating it rightward in order to get the perpendicular picture. Color now. That is the superior vena cava. Are you able to see, Dr. Srinivas?
Yes, we are very well, in fact.
Yeah, so that is the superior vena cava with the red color coming. Now I am torquing it, so that this is just confirming that the superior margin has been caught well.
Yeah, that we can see very clearly. Yeah.
Rotating. Yeah, that is the posterior margin which has gone in. And this superior vena cava, when you are seeing posterior to the superior vena cava, that round structure is the right pulmonary artery. What Dr. Ramya is showing with a arrow is the right pulmonary artery. So the position looks good. So again I am back to the inferior vena cava. That is the retroaortic margin. Any other questions about intracardiac echo? And then Dr. Avinash will be doing the Minnesota wiggle.
Pictures look really good, but how much does it add to the cost to the patient, intracardiac echo?
The cost, currently the cost of each intracardiac echo catheter is about 170,000 rupees. The catheter is in the United States of America supposed to be for single use. But in many other parts of the developing world, including in United Kingdom, there has been institutional policies, documents written about re-sterilization, and it can be reused in almost as close to 10 to 15 patients.
Okay.
So effective cost may come down to somewhere around 20,000 rupees if we are relying completely on it. But let me also tell you, this is not our routine imaging tool. We often do a transesophageal echocardiography in the outpatient clinic. I decide on the device size and then go ahead with the procedure mostly on transthoracic echo.
So what
Extremely rarely we do it on transesophageal echo. Intracardiac echo is primarily an academic tool.
Okay.
The downsides are you need another vascular access, but the positive side is the patient will be conscious and watching the procedure. There is no sedation, there is no respiratory embarrassment caused as like a transesophageal echo, or we don't need ventilations.
So you can avoid.
Dr. Ramya, you can show one thoracic echo so that people will be comfortable. Just thoracic one throw.
So you can avoid the TE altogether.
Exactly, exactly. So that it is basically comfortable for the patient. In US, Canada and all, where the anesthesia is very, very expensive, they try to always use an intracardiac echo, because if the cath lab interventionist is doing the procedure alone with his own imaging gadgets, then it makes it very simple. So this is the conventional like a thoracic echo probe. Yeah, it's looking good here. And as Dr. Ramya is showing, we are trying a small wiggle. You can see the separation now. And we are pushing it back. Parasternal short axis. This machine is Siemens SC2000, which is a 3-dimensional TE compatible machine, and it's also compatible with intracardiac echo. So this is the standard parasternal short axis. Again a small wiggle is made and the separation of the two discs, and we are approximating the two. Yeah, hands off, Dr. Ramya. IA down. Dr. Avinash will now demonstrate the release. Focus on the. So it has got a purple colored. Yeah, keep doing the fluoro. Purple colored, which he is now pushing it towards the. Now he has released the device. So the whole delivery cable has come out. We can again go back to the intracardiac echo. Yeah, now make it bigger. So now you can see the retroaortic margin, the posterior margin, color. That is the inferior vena cava blood that is coming in towards the lower portion, that is the postero-inferior margin, and diagonally opposite is the retroaortic margin. That is the inferior vena cava, and this is the retroaortic margin. Any other questions, Dr. Srinivas? I think Dr. Ajit will be ready with the remaining part of the CTO. I will just show you one fluoroscopic picture.
Thank you for the wonderful demonstration of the eyes, and very elegantly done, and then it was a master class. Really thank you for the demonstration of this.
Thank you. We missed the hospitality of Madurai, and I am sure the Madurai team will be taking good care of all of you, those who are from outside Madurai and outside Tamil Nadu.